Thank you very much, Anil, for being on time. And I think the session will come to end shortly, but I think it's been a very provocative session, and Dr. Palajani has finished his talk with an extremely provocative statement, which I think we should not leave unchallenged. I think we should ask him to defend that. I know Dr. Gupta has been kind enough to prepone the festivities for tonight, but I think we'll take some questions at the moment.
Dr. Pelajani, while handling multivessel disease and acute coronary syndrome, how frequently you handle only infarct-related artery and don't handle other arteries and say we'll do them after say 2 months, 3 months, or when is the condition when you do all the vessels in first attempt?
See, actually, all along it was a conventional training that you should do only the culprit vessel and perform the other vessels, which are standby vessels, as a planned procedure, maybe after 1 week. Previously, we used to say 4 weeks, then we came down to 2 weeks, then we said before discharge. So I think currently the recommendations should be that you do the culprit vessel right there and then only, and maybe before the patient goes home, you do the remaining vessels, and then you can call this as a complete revascularization. So I think that should be the current sort of a way of tackling these patients with a multivessel disease.
But you said surgical procedure is better, give better result, then will you subject them to surgery after some time?
No. We are talking about two different subset of, clinically two different subset of patients.
Okay.
Number one, patients which you're talking about are the acute patients.
Yeah.
Acute coronary syndrome, patients who have got an acute myocardial infarction, or patient who have got an acute unstable angina. Those are the ones which we are talking about doing a single vessel or a complete revascularization. What I was talking about, patients who have survived. I showed you the angiogram right in the beginning, who presented to us after 3 months. So patient who has survived the myocardial infarction, now he has got multivessel disease, poor ejection fraction, that is totally a different subset of patients.
That can be subjected to surgery.
There's a different clinical subset of
Thank you.
So very provocative talk. Suresh said that and I couldn't resist. Revived, randomized, I think 700 patients. One, is that a big number, sufficient enough to lend data and credibility as a treatment option to fall back on? That is number one. If you look little more in depth, that the rate of spontaneous MI in revived on medical management was higher, and there was a substantial jump or crossover to patients who had revascularization. Second thing is this revived completely, okay, yes, it's PCI. With CABG, you have the original trials of Rita Barry where multivessel, LV dysfunction, especially diabetes, CABG scores handover compared to medical management or PCI. So this is a little bit of a dichotomy in terms of what treatment option you should fall back on. There has been no clear demarcation. Naturally, once you've got more than 4 viable ischemic viable myocardial territories, patient would stand to benefit. The only thing this gives you some comfort is that medical therapy plus minus AICD or CRTP will buy some time and some quality of life for this patient.
Listen, Dr. Satyavan Sharma has selected the topics, and the opening topics were guidelines. Half an hour or 45 minutes went on guidelines. My last slide was on guidelines. You saw that?
Yeah.
My last slide was AHA guidelines, in which the AHA gives class 1 indication for CABG for patients who have got a multivessel disease ejection fraction less than 35%. Now, when these guidelines must have been written, they must have made sense. That's why Dr. Satyavan Sharma said guidelines. I am only reading guidelines. What I will do tomorrow in Breach Candy Hospital is different. And I'm sure you will also do totally
Absolutely.
different. Here is Suresh Vijayan, he will do totally different. But this is a teaching session. I think we have to therefore not jump. Doing an angioplasty is no big deal for you, for Suresh Vijayan or Dr. Satyavan Sharma or anyone who is present who has done an angioplasty. But we all have to look at science. And yeah, here is. That's why I showed you one slide in which the patient had an anterior wall infarction, an ostial LAD, stent was put in. I said patient went home after 48 hours. But what happens to him over next 2 years, 3 years, 4 years? Have you kept a watch on that?
No,
And
of
then
course,
how
but-
many patients you have followed to keep a watch on them?
Sir,
And
to-
compared them with the patients who underwent surgery? I think this is a science. And the other one is practice. Okay? Many of us don't practice science. We practice medicine. Okay?
Dr. Satyan Sharma sir is going to ask a question.
I just wanted one question to Nagesh. Nagesh, recently we had a meeting in Mumbai, on CAD meeting, which Dr. Mardikar has organized. And during that, there were a couple of talks by people who have come from England. And their consensus was that in low-income countries and even country like India, where costs, where we have financial constraints, the IABP, ECMO, these type of devices should not be used. Except, if there is some, is the general principle. Because ECMO, 30 days mortality has been almost 85 to 90%.
Yes, sir.
IABP, we all know the data, SHOCK 2 trial and all other trials, And what you concluded was, you can use Impella, which is actually out of reach of more than 95 or 98% of the people. So what will be your remark?
Sir, there are two things, sir. One is our country is a heterogeneous country, and we are practicing in a part of India where patients do come with resources. They have all kind of resources to support the advanced therapy. So when we are talking about such subset of patient, we should be well versed and we should have the courage to offer them the right kind of support, especially with Impella, which has shown in trials that it has a potential to reduce the mortality in ACS group of patients landing up with cardiogenic shock, provided we are doing it at right time. So when we talk about right time, they are using lactate level at the entry point to the hospital. If the lactate is more than 10, it's futile to put Impella. So I partially agree. We have to select our patients who are affordable and who can be benefited based on certain parameters.
Just the last question. If we add this question to your JJ group of population or KM group of population or large forget some patients of breech candy or some patients in isolated patients, as a general policy.
Sir, fortunately, I have experience of working in government institute. In JJ, I will not even offer IABP, sir, to the patient. It is not freely available,
So the
and there is no point scientifically to impress upon that. If like
absolutely.
TAVI, it has a mortality benefit, but for this, I will not insist.
Sure.
Asking the
See, where is Bharat? Bharat, and where is Ajit? Oh, Ajit is here. Ajit, all these patients, you are 50% criminal in this if it is crime. Because we take a joint decision whenever the first patient which I showed ostial left main, total circumflex, total RCA getting filled up retrogradely. Patient came to us, he has been shown the angio, I have seen the angio, we both agreed the patient should go for bypass surgery. Second patient, again anterior wall infarction, ostial LAD, he says, sir, kar dega. So now I can say, when Ajit says, kar denge sir, so I can't say, no, I can't do it. So this is a joint decision. But I don't know, it has been 2 years or 3 years. I have lost follow-up on the patient. I don't know how the patient is doing. Whereas revived patients were followed up. So I don't know what has happened to the patients.
Oh, so see,
पूरा कर देंगे sir.
there may be a time, see, this is just one trial.
No, I'm just trying to tell you,
And-
okay, you can't say 700 is a small number to randomize, remember that, to randomize 700 patients with all the viability studies you saw the revive. It's not easy. You randomize
No,
even
true,
for
true.
10 patients. You
Really,
find
true.
how difficult it is.
No, the question is that till now we have this one trial. And the indication and the class indications also do change over a period of time if some other trial comes up. So are we going to deny the patient who like proximal LAD as part of multivessel and you fix that and there is, benefit of ischemia in that territory and patient does well. Are we going to deny that on the basis of the result of revive trial? I am skeptical.
No. Then you are not learning science, let me tell you, frankly. Listen to me. No, I'm not trying to belittle you. Nobody has scanned this particular aspect than I have done. I have done practically every article I have gone through. There is no randomized trial which has shown that the PCI, if not superior, is as good as CABG in these patients. Ejection fraction 35% or less. You show me an article. Tomorrow I'll take you for dinner.
No,
Sir, I think,
Otherwise, you take me for dinner.
sir,
You show me an
no,
article.
till now it's clearly LV dysfunction CABG has scored.
One
That's why
more,
it is class 1 and this is class 2.
So the newer thought process or the concepts are to look at the fibrotic burden of the myocardium in a ischemic cardiomyopathy patient, and based on that you rationalize whether the patient will be kept on medical therapy or offered revascularization. So I feel this is a gray zone and the debate is never going to end. The coming years will add to our knowledge with lot of new trials and new concepts.
Yeah. Go on.
no,
Sorry.
I
think
last quick
just
comment.
one he's inviting us for dinner.
Only plastic, sir.
Okay. I think what we need to understand is, and what Nagesh has said, moment you start detecting excessive amount of diffuse fibrosis in the myocardium, your arrhythmic deaths start to increase rather than heart failure deaths. And I think that is something that we need to look at very carefully when you, so the role of ICDs in those things would probably come. The only disappointing thing about the most disappointing about Revive was that there was no surgical arm. I would be happy if there was a good medical therapy, then good medical therapy, angioplasty, good medical therapy, surgery. That never got done. And I think that's the lacuna for Revive. Yeah.
And all people like you, me, they stood up. No interventional cardiologist wanted to believe that Revive trial is this thing. The person who was presenting himself, a very renowned interventional cardiologist, he told, the first message I want to give to you all guys is that medical treatment has improved tremendously. And both arms, the medical treatment and this thing, he told, we want to buy it or we don't want to buy it is different. But this is what the data is. So, and say the guidelines and how we approach to patients of ischemic cardiomyopathy is going to change. Whether you will look at scar burden, fibrosis, ischemia, this thing, multiple things, but this is what it stands today.
So I think if we had known this session was so interesting, we would have kept it right in the beginning.
Yeah, I think everybody is thirsty and
Next
hungry.
time, I think.
Close. So I would thank all our speakers. for
So
the
just
excellent
a couple of
presentation.
quick things. Sir, please.
And I think I call this session for a close because I know I'm thirsty. I don't know about you guys.
No, so just a couple of quick announcements again to reiterate that we'll be having our GBM on the S level where the lunch was, and that will be followed immediately by dinner. In fact, dinner is opening at 7:30, so all are requested to proceed there whenever you can. And tomorrow morning we start again at 9:30 sharp, and there are many interesting topics. Again, we have a mixture of coronary, structural, clinical, then there are newer modalities of treatment which are going to be discussed. So I request all of you to be here at 9:30 and participate in the proceedings, be with us right till the end. I think this can be a good overview of whatever has happened in cardiology over the last year. Once again, I thank all the chairpersons, all the speakers for today, for sticking to time and for covering the topics in a very comprehensive way. And please join us for the dinner, and we'll meet tomorrow again. Thank you.